Well, good afternoon. My name is Jerry Nick, and on behalf of my co-moderator, Jennifer Gumbalot, I'm really happy to welcome you to Symposium 5, an evolving understanding of ETI, potential mechanisms of lingering disease. I have no commercial relationships to disclose. I do want to thank my funding sources and also all our collaborators. So of course, we all know that there's been tremendous benefit on average from the administration of ETI to our patients with responsive genotypes. And along with the benefit, however, we've seen quite a bit of variability in response. This is a plot from the phase 3 trials of ivacaftor in either one copy of F508 or two copies of F508, the absolute change in percent predicted FEV1 from baseline to week 4, with on the left axis we see the participants in each cohort. And here is a plot of patient-reported outcomes measured by the CFQR respiratory domain, again extending from the number of patients, participants in each category with excellent response on the right and little or no response on the left. So in the individual patient, we do encounter people who just seem to have little or no response, or even in this phase 3 trial, which was designed to prevent or reduce variability, we still see people that even had a decrease in lung function or a decrease in quality of life. And on the other side of the spectrum, we have people that really struggle with our dosing and with side effects and intolerances of various kinds. So most of us here in this room question, what is the role of ETI pharmacokinetics in determining individual response? So we hear frequently in clinic, pretty much on a daily basis, from people who have struggled with the full dose of ETI. This is a patient voice segment from Amber, who was recorded last week in our clinic by Kathy Chacon, who is our program coordinator.
My name is Amber. I am a mother of 3 and a patient at the Colorado Adult Clinic. I've had frequent exacerbations in the past, requiring hospitalization of 2, 4, or 5 times a year due to Pseudomonas that is highly resistant to most antibiotics.
Tell me about your initial experience with tezacaftor.
When I first started several years ago, the increase in lung function and overall lung health was almost immediate. Unfortunately, I did have some mental health side effects with depression, anxiety, mood, memory, and it was noticeable to my family, my kids, really to everybody around me. I was basically a completely different person. And due to the severity of it, I did stop taking tezacaftor.
Tell me about your current experience with tezacaftor.
Over the past year or so, I did start taking it again, but we're at a reduced dose where I'm only taking 1 orange pill a day and leaving out the rest of it. And along with that, I've also been seeing a psychiatrist to help with treatment for the side effects of it. And with those combined, it's been fantastic with my lung health, and then overall exacerbations have greatly decreased.
So I think that's pretty familiar, to most of us in the clinic. So for the last year or so, we've had the availability of ETI level testing in our clinic at National Jewish. And I just wanted to end by showing you just a quick look at those data. These are the 3 components with the black circles representing individuals on a full dose 6 hours after their morning dose as part of a validation study. And the red triangles are individuals on a full dose who were on average 7.2 hours after their morning dose, who were seen in clinic, just random draws. And the gray square is the Cmax plus or minus 1 standard deviation. So you see that in the clinic, there's a lot of people just with random levels who are at or above the Cmax, and just extensive variability in the levels of all three components. But what's really interesting is if you look at people who are on a modified or reduced dose, and some of them a significantly reduced dose, also about 7 hours after their AM dose, we see considerable overlap with people on the modified dose and people on the full dose. And in many cases, people on a reduced dose have achieved a higher level than an individual on a full dose. So definitely a lot to think about in that regard. And you can hear more about this study in Workshop 25. Sylvia Caceres is presenting the data in a more detailed manner and also in poster 134. So our session today is going to really focus in on mechanisms of variability in the response to ETI and what we've learned so far. Starting off with Jennifer Gumbalot talking about the variability in response in relationship to pharmacokinetics, and then Paul Berenger with what we know and don't know about modeling the ETI dose. And then Jamie Duckers is going to talk to us about the role of gender and the response to ETI. And then Scott Segal is going to finish with some of the very latest data from the PROMISE study that is focused specifically on the inflammatory response. So with that, I'll turn it over to Jennifer.
Well, thank you so much. And I wanted to thank the organizers for the conference and also Dr. Nick, my co-moderator. And so I'm going to talk about what PK's got to do with it. I'm Jennifer Gumbalot. I'm from the University of Arkansas for Medical Sciences at Arkansas Children's Hospital in Little Rock, Arkansas. These are my disclosures. All right, so I am a pediatric pulmonologist by training. I also have a PhD in genetics, but I am not a clinical pharmacologist. So sometimes I get asked, what does a pediatric pulmonologist want to do with pharmacokinetics? And so my interest is really in precision medicine. That's how it really started. And so thinking about what are the unique differences between each patient so that we can match the right medicine at the right dose to the right person. And so when we study drugs and we develop them, we are basically getting population averages for our clinical trials. So these are not necessarily individuals that we're thinking about. At this time, we're thinking about groups. And so such a group is seen on the slide up there, where a lot of the people have very similar characteristics, and then of course there are additional people within that group that have differing characteristics, and so they may not respond exactly in the same way. But precision medicine would allow us to take unique data for each of those patients, for example, genetic variation or blood concentrations or other unique data, and use that information to figure out who's going to respond to the normal dose, who's going to respond to a lower dose, a higher dose, or an alternative medication altogether. And the overall principle is to really improve clinical outcomes and mitigate that need for dose titration and reduce side effects. So in today's talk, we're really going to focus on plasma concentrations, or in other words, therapeutic drug monitoring for precision dosing. What's PK got to do with it as far as modulators are concerned? Why might we want to consider doing this? How do we do it? And are we ready for this? So the first thing we want to talk about is our exposure-response relationships. What are the relationships between concentration and response? And so what you're looking at on the screen is actually an exposure-response curve or a concentration-response curve. Along the x-axis would be plotted the concentration, and on the y-axis is a biological response. And the idea is that as you increase the concentration, you should start to see some sort of a biological response if the drug is effective. The relationship is typically not linear, as you can see here, and as you go further along on the higher and higher concentrations, eventually reach a maximal effect or a maximal response. And then you can mathematically sort of calculate what the effective concentration should be in this population for effective concentrations. For modulator therapy, those thresholds were defined as EC50 and EC90, so effective concentration 50 or 90. Below the EC50 would be considered a suboptimal response, and above the EC50 would be considered the expected response. We don't really have a lot of information about what happens when you push the concentration higher and higher, but we do know that for most biological measures, there is a maximal effect that you can reach above which you cannot have further biological improvement. So that's a ceiling effect. And so as you get concentrations higher and higher, you will have no further biological improvement. So the idea is that, can we make these sort of buckets of what the concentrations are? If they're really high, do we have possible toxicity or side effects? A lot of times this is identified in clinical trials. For modulator therapy, we really didn't see a lot of that. And then the next bucket would be the concentrations that would elicit effective drug and response and minimal side effects. And then, of course, what we'd like to avoid is a suboptimal drug response, which is the lower concentrations. But as I'm going to show you now, it's not quite that simple when you look in the real world and you look at actual observed responses. And so how do we use this information? So what you're looking at here is data that's actually derived from an ivacaftor monotherapy study that I did and published in 2022, where we were looking at ivacaftor as the first modulator that was approved and is the one that we know the most about. And we took data from real-world people taking this drug and simulated what it would look like if someone started it anew. And basically, we can distribute it into the different percentiles. And in this case, we looked at the 25th to 75th percentile. And as you can see, we have a wide range of where people might be to lower concentrations versus highest concentrations. And it's very tempting to want to take this information and put it right into one of these buckets really simply. The high concentrations, we think, oh, that's really, really high. Maybe there's toxicity and side effects. And we have low ones that are maybe cause a suboptimal response. But again, we don't necessarily know that, even though we do see this wide range of concentrations. With observed responses with biologic response in modulators and modulator concentrations, we actually see that the relationship is much more messy. And so what you're looking at here is actual exposure response, again, for ivacaftor, because we know the most about it and have some of the most granular data about it. Along the x-axis is the ivacaftor concentration, and on the y-axis is the lung function change from baseline. And what you see here are a range of doses that were tested with a range of concentrations that were found in those patients and the actual responses that they had to that drug in that study. And so the circles really kind of look at the groups of different concentrations that we see, which pretty closely adhere to the different doses that were given. But if you look carefully, you will see that there's actually a variety of people who are quite outside of those circles. They're not fitting neatly within those different buckets like we just talked about. Some people who are at the very highest dose had some of the lowest concentrations. Some people with the highest concentrations had some of the lowest responses. So it's not as clean as what I just showed you, was what we think about on a population level when you look at individual responses. And then when you look at the sweat chloride response, the relationship gets even messier. The biological response is quite variable. The concentrations are all over the place. They're still roughly clustered together as you would expect. Higher doses are going to result in higher concentrations. But the relationship is imperfect. And you don't always have higher concentrations with higher doses. And you don't always have lower responses with lower concentrations. It's more complex than that. The next generation with dual combination therapy looks at tezacaftor, ivacaftor. And so what happened in this graph is that we have the average concentration of tezacaftor on the x-axis and the change from baseline lung function on the y-axis. The IVA treatment alone is listed in red, and then the IVA plus tezacaftor was listed in blue. And it's really hard to see the red line in there, but it's basically flat, meaning that in this population, there wasn't a response. But the blue line did have a change, and that's part of how tezacaftor, ivacaftor came to be approved. But what I want to really draw your attention to, again, is the variability in the biological response and the concentrations. As you can see, as you go further along the x-axis, higher and higher concentrations do not uniformly result in an increase of lung function. And same thing, you can have some of the lower concentrations resulted in some of the greatest responses. So it's just not a simple relationship when you're thinking about individual people who are taking these medications. So this is a session about ETI, or triple combination therapy. So why might we want to monitor concentrations? Dr. Nick has already alluded to some of this, and we don't know as much about ETI on the granular level as we know about the previous two drugs that I talked about. So let's take a look into that. So some of the information that we have is regarding the effective concentrations for triple combination therapy, which are not exactly the same as for monotherapy or dual combinations. And what you're looking at here is actually Dr. Tsai's publication from 2020, where they were actually modeling the transition from an earlier modulator drug to ETI. And what you're looking at is basically a simulation based on real data to figure out how easily someone was able to make that transition and maintain concentrations within the effective concentration range. The effective concentrations are marked in green, and the goal was really to try to keep most patients at or above EC90. EC50 or above is good for responsiveness, but EC90 is really the target because so few adverse events were shown at higher concentrations that the idea was to get the maximum number of people at the maximal response. And from that perspective, that goal was achieved. Most people, based on this simulation, are at or above that EC90. And as I'll show you in subsequent slides, that goal was achieved overall in the real-world data that we have so far. I'm pointing this out, and you'll see this little graph again a few times to point out where we are on the exposure response curve. Although it's imperfect, this can guide us through thinking about how we can interpret some of this data. So thanks to Dr. Pigliasco from Genoa, Italy, and her publication in 2023, we do have some limited exposure response data for ETI. This is just ivacaftor, but actually all the compounds were tested, and they were looking at the relationships between concentration and lung function. And in this particular paper, no associations between the concentration and the lung function was seen. But in part, that is because the concentrations that were tested in this real-world study were all above that EC90. That dotted line shows you where that is for ivacaftor, and the diagram on the right shows you where we are in the exposure response curve. We're already at the highest concentrations where you would expect to see no further maximal effect. And again, it's not a perfect association, but we wouldn't expect to see an association here. My own data has shown more information about concentrations above the EC90. So again, this is some data from a sub-study from the Czech study. It was a pharmacokinetics study performed in 6 sites across North America, and I presented it actually in 2022. But in this case, for today, I pulled out all of the data above the EC90 in this population. And what you can see here, if you look at the biological response on the y-axis, which in our case was sweat chloride, and the three compounds on along the bottom, the R value is a measure of association of the two variables, and it is not clinically relevant. The p-values are non-significant because, again, at this point, you can push up the concentration, but you wouldn't expect to see further improvements. Below the EC90, however, is a different story. At this point, we are equivalent to this part of the exposure response curve, and then you start to see those associations. The R value is clinically significant, and the P value is statistically significant. And so we have also looked at this in a few different ways and performed sensitivity analysis, and this always does hold up. The lower your concentrations go, as far as sweat chloride as a biological measure is, the worse your sweat chloride will be. We also have data, as Dr. Nick showed you earlier, and Sylvia Caceres poster 134 and workshop 25 is going to go into more detail on, that we have a similar spread of data, a variability of this data from National Jewish, now at this point from a national sample. And so what you're looking at here is their validation cohort at full dose, a clinical cohort at full dose, and a modified dose cohort as well. And as Dr. Nick already said, there is significant overlap between the full dose and the modified dose. But what I want to draw your attention to is that, we can actually really, now that we have these resources, start to evaluate these associations even better in real-world use. So as I mentioned, we're really interested in the effective concentrations, which again should show some associations between exposure and response. We do have to be cautious though, because as you move to this linear part of this curve, you could be risking lower and lower responsiveness. And so we have to understand that relationship when making these clinical decisions. We also do have a lot of people who are at concentrations that are above the EC90 and are very high, where you would not expect to see significant improvements at higher concentrations, suggesting that dose adjustment or dose reduction is viable for some people. This is the kind of data that we need to have to evaluate these relationships further and understand how to interpret the values that we receive. So how might we use this information? So one of the questions that I get asked a lot is when to collect a sample. So in order to demonstrate that information or that concept, I'm showing you concentration time curves. These represent individuals' absorption, distribution, and elimination of compounds. This is actually a study that I did with Dr. Ramos at the University of Washington, where we compared lung transplant recipients and patients with CF who have not had lung transplant. And what you're looking at here are all of the curves represented each individual in those studies. There's about 26 people in there, and we collected 9 different samples over time. And the effective concentrations are shown here in the gray area. And what I want you to appreciate is that each individual is different. The time when they reach their maximal concentration is different. The time when they have their lowest concentration is different. And it's not a simple curve. Sometimes it goes up and down a little bit. And if you want to figure out when to time the testing, that's very challenging. As an example, if a patient takes a medication at 7 a.m., you could get the trough. You know when that's going to be just before they take the drug. But getting that in a clinical setting is very challenging. Most of our clinics are not open at 6:30 in the morning, and most of our patients don't want to come at 6:30 in the morning. And so trying to get a peak may be more feasible. So if you go with the time to maximal concentration for tezacaftor, which is shown here, you're looking at 9 a.m. That's the average peak. But this patient is at 11, and this patient is at 12. And if you think that 5 hours is a peak, well, this patient for that particular time point is the lowest concentration. And if you use that and assume for clinical purposes to decide whether or not they need a higher dose or a lower dose, it's problematic. And you don't know this when they walk in the door. You just know the one time point that you have. And now you're multiplying that times 3 different compounds. Again, each patient takes their medication at 7 a.m., which has all 3 components. And in the case of ivacaftor, the lowest concentration is typically closer to 1 hour, and the average peak is 4 hours. But as I just showed you, the average peak for tezacaftor is at 2, and elexacaftor is actually at 6. So the peaks vary for patients, for every patient and for every compound, and that makes it very complex to figure out exactly when are you going to take the one time that's going to capture all 3 of them well. So in summary, the dose-response relationships are not linear. Many factors influence real-world concentrations and responses within the same dosing scheme. The exposure-response relationships are also not linear. Many factors contribute to the response, even if you have similar drug exposures. The concentration data, as I showed you, is inconsistent or highly variable between individuals and over time, making it very challenging to pick out the one time that's going to help you in your clinical decision making. And then the clinical outcome data is also highly variable, which is why we want to know all this information in the first place. And to conclude, changing the dose may be safe for some individuals, but not for others. And our task as researchers and physicians is to figure out how do we identify those people on the front end and monitor them. We don't yet have all the information or tools to accurately understand the exposure-response relationships in clinical practice. And we don't yet have all the tools to translate single samples into clinical care decisions. But we do have a whole lot of opportunities to address this knowledge gap and improve care with lots of opportunities from across the world with more and more data emerging every day and the availability of reference laboratories to help us understand how and when and why we might do therapeutic drug monitoring. So I'd like to thank the participants and research teams who make all of our work possible. I know I can't acknowledge everybody. I'm sure I forgot some people, but I'm trying to capture everybody because without them, none of this work would ever get done and we wouldn't answer any of these questions. But I also want to thank all of the colleagues and collaborators who contribute to the successful conduct of these studies and would be happy to take questions at the end. At the end, I would like to...
Well, actually, we do have a few minutes now. We can take some questions, and then we'll also save some time at the end to ask everyone questions. And I just remind you that we are accepting questions on electronically, but then also the old-fashioned way too. Yes, please.
Hello. Yeah, thank you, John Dickinson from Nebraska. Great talk. As a clinician, this is all looks daunting, right? And the other question I have for you, I think the scenario would be I have a patient in the hospital, end-stage lung disease. And I think a lot of us are wondering, what are the pharmacokinetics? What is the role of ongoing inflammation or exacerbation on your PKI levels? Does that play a role? And should we be testing them under non-exacerbating conditions or under homeostatic conditions?
I think those are really good questions. And I think a lot of things happen in the inpatient setting that can affect pharmacokinetics, IV fluids, other drugs that are being used, and other things. And so I don't recommend doing it during active exacerbations or in the inpatient setting, and try to get that, a steady state level if they've been on the same dose for at least 2 weeks, and ideally not actively sick. But I'm not aware of a whole lot of data right at the moment on the effect of inflammation on PK. I would say that people who have severe malnutrition and gut issues could have significant effects on absorption, which we still don't have a whole lot of good information on in terms of like the how the disease state is affecting that. But it is something that should be considered as part of the variation in these drugs.
Thanks.
Go ahead, Dick.
How much of the variability is due to the amount of fat that's taken at the time of dosing?
Yeah, so that's a really good question. Two of the drugs are, well, they're all lipophilic, but two of the drugs are particularly affected by food intake. Tezacaftor is not as affected for whatever reason, but elexacaftor and ivacaftor both have significant variability. Ivacaftor, I know is for sure is at least 40% variability with or without food. And so the recommendation on the label is to take it not only with food, but with a fat-containing food. The specific amount of fat that is needed is not known, but based on other types of drugs, some fat is necessary, but huge amounts of fat is probably not. I actually, one of my colleagues is presenting some of this data, or may have presented earlier today, and that we did a small pilot study evaluating different levels of fat content of meal and diet composition, and saw no significant impact on concentrations, but we did not evaluate a low or no fat diet because that's not appropriate for these drugs. That wasn't what we were interested in that study.
Hello, I'm Alan, a PhD candidate at USC Mann School of Pharmacy in LA. So what I'm wondering is that we have a CF clinic at USC, and we've tried dose reductions of ETI before. I'm kind of curious to see for your like EC50 or EC90 values, do you have like the exact like numbers for those concentrations, and also like if you have the FEV1 values as well?
So, can you clarify your latter part of the question, the exact numbers for FEV1?
I meant like so I saw like the EC90, for example, was like sweat chloride. So do you have like those like EC50 or EC90 for like the FEV1 efficacy?
Right. So you're bringing up a good point that the EC50 and EC90 for sweat chloride versus sweat chloride are probably not exactly the same. And that was shown in previous studies for other modulators. But for ETI specifically, they were only looking at lung function in Dr. Tsai's 2020 paper, and that's the most detailed data I have. The exact numbers for EC50 and EC90 can be derived from that, and I think that they're reported in a couple of different papers, maybe some of mine, and Dr. Behringer going to follow up as well. But those are, available publicly. They're not explicitly stated as much as we would like, though.
Got it. All right. Thank you.
Go ahead.
What wonderful work. Thank you very much. A lot of this work seems to be outside of kind of Vertex, and I guess I wanted to ask two questions. How helpful or not helpful is Vertex to this field? And more importantly, what should we as a CF community ask of Vertex to help us with this?
So I am incredibly grateful that we have a pharmaceutical company that was interested in developing CF2 modulators, for sure. And the initial drug approval process is, expensive and complicated. And most of the time after a new drug, especially a new class of drug is approved, a lot of academic work goes into figuring out additional details that are not required or part of the original drug development. And so having a lot of studies like this is not unusual for drugs as they are newly approved. In terms of what we could ask Vertex to help us with, I would really love to have more detailed data from the original clinical trials available.
My question is more to do with the fact that this is a complex response that we're measuring, because when we take ETI, there's not an immediate effect. It's not like a typical in vitro drug receptor response that's immediate. Instead, we're taking a compound that somehow makes it into the serum that then has to get into the endoplasmic reticulum and then is not receptor mediated and then somehow cause a response. So are there any ideas out there about surrogate markers for our downstream effects, which may occur days or weeks after we initiate the pharmaceutical product, that could help us better address this issue up front? And how do we know that even absorption is the same from day to day? Or do we have any markers for looking at those kinds of things?
Yeah, so I think the markers that we currently have available are the same ones that we've used for most of the clinical trials, like sweat chloride, lung function, LCI, and so on. And so I don't think we have some that are better or different specific to pharmacokinetics. There has been some studies looking at cellular levels. I have done some of that work that can be helpful using nasal brushings, for example, that are easily accessible, but not everybody's going to be able to do that. And I do think that there is probably day-to-day variation, and it's going to be an ongoing question for research. People are very interested in, if we use sweat chloride as a marker, then how closely associated is it? And as I showed you this, it's a messy relationship. But it's still very interesting about, can we see how sweat chloride is changing over the course of a day? Or if we had, more data, more frequent data, more easily obtained data, if we could evaluate, capillary concentrations or saliva or other things, are those going to be markers that are going to be more easy for us to obtain and useful and highly correlative? And I think the answer is that we don't know yet, but there are a lot of people interested in following that. I don't think I really answered your question, but I think there's a lot of research opportunity there.
I think we should stop there. We have a couple online questions that we'll save for the end.
Okay, good afternoon. I want to thank the session chairs for the invitation to present today. And I think the introduction that was just given on PK variability and in terms of clinical response is important. It's a good introduction to what I'll be talking about today, which is really looking at ETI dosing and the impact of PK/PD modeling in determining optimal dose. I have no relationship to disclose. So much of what we know about dosing of ETI comes from the clinical trials during drug development, as well as some post-marketing studies. And I think that data was just shown with the last speaker, that was a modest dose response in the phase 2 studies. But importantly, the combination of the phase 2 and phase 3 data was analyzed pharmacodynamically and showed a decent relationship between plasma concentrations and improvement in lung function and sweat chloride. And that EC50 and EC90 data is helpful when trying to determine alternative doses in the settings of unique drug interactions or adverse effects. And so I'll be referring to those also in my talk. The other things that we do know from the drug development process was that the dose adjustment is needed with the CYP3A inhibitors, and then also that dose adjustment needed in moderate hepatic impairment. So this just shows a slide of the hepatic metabolism of ETI, and all three components are extensively metabolized by CYP3A. And that's why these drugs are prone to drug-drug interactions involving CYP modulators that we might see in clinical practice. So CYP inducers can reduce the plasma concentrations, putting the patient at risk for loss of efficacy, while the inhibitors can increase concentrations and increase the risk for side effects. The other consequence of being heavily metabolized in the liver is that liver impairment can reduce the clearance of the drug, and that's why dose adjustment is needed in moderate hepatic impairment. And then finally, another consequence of extensive metabolism in the liver is the generation of reactive metabolites, which can cause drug-induced liver injury, and I'll talk briefly about that in a few minutes. Also shown on the slide is that ETI is a substrate as well as inhibitor of several transporters. The clinical significance of those is currently not known and is actively being researched. So just to be aware, there's other potential drug interactions beyond just CYP3A. So this shows the results of the trials, drug interaction styles done during drug development, and it involved looking at index CYP inhibitors and inducers. So itraconazole and ketoconazole are index strong CYP3A inhibitors. And as you can see, the concentrations and AUC ratios went up significantly for all three components of ETI, with the most increase with ivacaftor, because that's the most sensitive CYP3A substrate. And then with the moderate index inhibitor fluconazole, there was also an increase in plasma concentrations, but it was less so than with the strong inhibitors. And then finally, the strong CYP3A inducer, rifampin, caused a substantial reduction in ivacaftor concentrations, about a 90% reduction in the plasma AUC. Although it wasn't studied, elexacaftor and tezacaftor also expected to be significantly affected because they are also CYP3A substrates. So based on these studies with the index inhibitors inducers, guidelines were developed for the use of clinical inducers inhibitors. So with any strong CYP3A inhibitor, the dose should be reduced to 2 orange tablets twice weekly. With a moderate inhibitor, it's 2 tablets of the orange, alternating 1 blue every other day. And then, importantly, in the presence of strong CYP3A inducers, the use is not recommended while on CFTR modulator therapy. While patients with liver disease were not included in the clinical trials during drug development, there was a post-marketing study in patients with moderate hepatic impairment. The participants were given a half dose of ETI for 10 days. And this shows that there was a modest increase in the plasma AUC for all three components in patients with liver disease when compared to healthy matched subjects. So based on those pharmacokinetic changes, dosing guidelines were developed. No dose adjustment is needed for patients with mild liver disease. However, in those with moderate liver disease, it's an alternating dose with 2 orange tablets in the morning and the next day 1 orange tablet. And in patients with severe liver disease, the drug is not recommended because there currently is no clinical data in that population. My graduate student, Alan Shee, is presenting tomorrow in workshop 28 on PK/PD modeling of these dosing recommendations, as well as some alternative dosing regimens that have shown up in patients with hepatic impairment that were published recently. So that's what we know about ETI dosing. What do we not know? So I've selected several clinical scenarios where dosing information is not yet known. The first looks at ETI dosing during transitions with drug interactions. So the dosing information I just provided assumes that the offending drug as well as the modulator are going to continue together indefinitely. But often in the clinical setting, an offending drug is started and then stopped. So how do we adjust the dose of Trikafta during the onset and then after the drug stops? And a good example is nirmatrelvir ritonavir. A second clinical question that comes up is, what about the use of a moderate CYP3 inducer, such as rifabutin? Can those two be given together? What effect might that have on ETI dosing? And then finally, as already stated, reduced dose ETI is used quite extensively to mitigate adverse effects that we see in the clinical setting. But there's very different doses that have been used, and what is an optimal dose that's going to result in some minimal therapeutic effect? So we use modeling to address that. So one of the tools that we can use to answer these questions is physiological-based PK modeling. And this tool is useful for predicting the pharmacokinetic behavior of drugs in humans based on in vitro data as well as some clinical trial data. So on the left, it's basically showing the components of a PBPK model. It includes system data, which has data on the population of interest that's going to receive the drug, looking at age, weight, and perhaps if they have hepatic impairment. Then we need drug data. So this is the physical chemical properties of the drug, as well as in vitro data on transport and metabolism of the drug. And then finally, there's the simulated trial design, the dose, the route and frequency, and whether there's co-administered drugs. The utility of these PBPK models is they can give guidance on dosing where clinical trial data does not exist. So, for example, with ETI, when it was initially marketed, there was no data on the drug pharmacokinetics in patients with liver disease. However, a PBK model was developed, dosing guidelines were included, and that was approved on the FDA approved label, the use of that dose. So certainly it can be useful in regulatory submission to provide guidance on dosing where clinical trial data may not yet exist. On the right is a graph just showing the increased number of drug applications that go into the FDA with incorporating PBK model data just for that purpose. This shows an example of the workflow for PBPK model development, verification, and application. I'm not going to go through it in detail, but basically we're inputting data from the drug as well as the patient population. And then the important step is the model verification phase. So with these initial models, you need to be able to predict the published data on single and multiple dose PK data. So this shows data from our initial PBK model where we predicted the drug concentrations given standard dose ETI, and there was a very good agreement between the predicted and the actual observed values from the clinical trials. When evaluating drug interactions, the second verification step is to evaluate the predicted drug interaction using the index inhibitors and inducers. So this shows our PBK model predictions for itraconazole when given with ETI and rifampin given with ETI. And you can see the predicted area under the curve ratios very closely matched with the observed values. Once you have a verified model, the application is that you can use this now to predict other drug interactions that may be encountered, other medications the patients may be taking that are inducers or inhibitors of 3A4. It can also be used to look at alternative dosing strategies, such as the case where you have adverse effects and you want to look at using a reduced dose regimen. Or you can look at alternative dosing, for instance, in patients with hepatic impairment. So the first example of our PBK model was looking at the drug interaction between nirmatrelvir and ritonavir. So nirmatrelvir is an antiviral that has activity against SARS-CoV-2, but it's packaged with a strong CYP3A inhibitor, ritonavir, and it's used that way to prolong the activity of the antiviral. It's prescribed a typical course of 5 days. So the question is, how should ETI dose be administered when there's short-term concomitant use of ritonavir? So to address this question, we simulated the standard dose regimen of ETI in combination with the 5-day course of ritonavir. So shown in red is the concentrations going up during the course of the 5-day ritonavir. The green is standard dose with no ritonavir. So on average, the Cmax concentrations increase from 2 to 10-fold in combination with rifampin. But more interestingly, if you look to see the concentrations did not recover to the baseline until day 15, which is 10 days after the ritonavir was stopped. So this suggests that we definitely need to reduce the dose of the medication when it's given in combination with ritonavir, but also that we probably need to delay the resumption of standard dose ETI after the ritonavir is stopped. To look more closely at the mechanism of why this is, we simulated the pharmacokinetics of ritonavir, and this shows the plasma concentrations over time. And within a day after stopping the ritonavir, you can see that the ritonavir is completely gone, which is consistent with its relatively short half-life of 3 to 5 hours. However, on the right, you can see that the activity in terms of CYP inhibition persists for several days after. And that's because ritonavir is a mechanism-based or irreversible inhibitor of 3A4, and it requires time for new synthesis of the enzyme to recover the activity. So it's important to recognize that there's some additional mechanism-based inhibitors that I highlighted on the slide here. So based on that data, we simulated the optimal dosing regimen, which turned out to be 2 orange tablets on day 1 and 5, and then resumption of standard dose ETI on day 9, when the CYP activity was expected to be 60% of the baseline activity. A second example where we use modeling to look at drug interactions is with rifampin. So rifampin is a guideline-recommended treatment for MAC pulmonary disease. However, as mentioned earlier, it's contraindicated with modulators because of its significant CYP induction effect that can lower the levels, and that's included on the current product information. And that's substantiated by a case report of a patient who was started on rifampin while on a CFTR modulator. The patient experienced acute pulmonary exacerbation and failed to recover to their baseline lung function. However, one thing to point out is that the CYP3A4 induction effect of rifabutin is known to be less than rifampin. A study with luceravine, which is an antiviral, and also a CYP3A4 substrate, showed us 85% reduction in the area under the curve with rifampin, but it was only 34% with rifabutin. So this raises the question of whether rifabutin can be co-administered with CFTR modulators. So we then used our PPK model to simulate what the pharmacokinetics would look like in combination with rifabutin. And looking at ivacaftor, you could see there was about a 70% reduction in the plasma AUC, which is pretty substantial. But when compared to lumacaftor, which was an 80% reduction, and rifampin, a 90% reduction, it was a bit less than that. Considering that ivacaftor is packaged in combination with lumacaftor as a dose adjustment, there is potential to administer rifabutin with dose-adjusted ETI. The one challenge with that, of course, is how's the insurance company going to authorize payment for the increased costs associated with it? So because of that, we then simulated standard dose ETI with rifabutin and performed a pharmacodynamic analysis to look at the concentrations in relation to the EC50 or EC90 values. And as you can see from this plots here, shown in red is the concentrations that dropped during the rifabutin treatment. But with all three drugs, the plasma levels exceeded the EC50 value, and with ivacaftor, it was just slightly below the EC90 value, suggesting that standard dose ETI with rifabutin is expected to have some pharmacologic activity. We performed a clinical trial PK validation study of the interaction, which largely confirms these results, and that's presented by my graduate student Madeline Sanders tomorrow in workshop 28. We also recently published a small case series of patients that were on rifabutin with CFTR modulators, and this shows the lung function improvement that was seen in all three patients after starting rifabutin. So based on the PBK modeling data as well as the small case series, it's a positive that potentially modulators could be used with rifabutin, and clinical trials to validate the efficacy and safety of this are warranted. ETI dose reduction, as mentioned, is a widely practiced in clinical practice. This is due to the adverse effects that are seen, particularly mental health adverse effects, as well as increase in liver function tests. In clinical trials, 8% of patients experience ALTs greater than 3 times epinormal, and drug-induced liver injury cases have been reported in the FDA adverse effect reporting system. There's been several published case series of ETI dose reduction to manage these adverse effects, but the efficacy and safety has not systematically been evaluated as of yet. The other issue is that the doses used in these reports vary widely. So we decided to use PPK modeling to look at the reduced dose regimens and compare them to the EC50 values to see whether they would still exceed this value and expect a therapeutic benefit. So this shows the results of the simulation with a full dose given every other day, which ends up being a half dose. And you can see that the concentrations, including the lower 5th percentile, all exceeded the EC50, suggesting that there's likely to be continued benefit with reduced dose ETI at this dose regimen. We also reported a case series of patients that were received reduced dose ETI due to elevations in liver function tests. About 50% of them had ALT greater than 3 times the upper normal. The onset ranged from 2 to 24 months, and the majority of them received alternate day or half dose ETI. The LFTs improved or resolved in 92% of the patients. 3 patients experienced increase in cough and sputum production. However, there was no change in the lung function in any of these patients after dose reduction. So these results, as well as the other published case series, suggest that prospective controlled studies of ETI dose reduction are certainly going to be warranted. So in conclusion, the POP-PK-PD modeling, I think, has established dose-response relationships and its identification of EC50, EC90 targets that help in defining optimal doses. ETI dose adjustment is necessary in the presence of CYP3A inhibitors, as well as in patients with moderate hepatic impairment. And I hope I've convinced you that PK modeling is a useful tool to evaluate dosing where clinical trial data is lacking. Just want to acknowledge my graduate students who contributed to the data, my collaborators, Dr. Hong, who's done a lot of the PBPK modeling in SimSip, my longtime collaborator, Dr. Rao and Dr. Chung, and then funding from the CF Foundation and Anton Yelchin Foundation. Thank you.
We do have time for a few questions. And then again, we'll have time for questions at the end. And please feel free to go ahead and enter it on your phone or come up to the mic. Yes, please.
Matt McGraw from University of Rochester. Great presentation. Any role of genetic testing for CYP3A genetic variants and how that might play into your model?
Yes, certainly. And there was a session this morning that presented on that. So since it's highly dependent, metabolism is highly dependent on CYP3A, polymorphisms where the metabolism may be altered certainly are going to be important. And the model can incorporate genetic variants. We're in the process of looking at that with our model.
Hi, Astrid Menendez. I'm UAMS and a peer of Dr. Gimbel. Actually, she's my boss. I just wanted to ask you about liver function. You're using 3 times baseline. Have you looked in these patients about the creatinine kinase? Because you don't have to have such an elevated or increased number on your liver enzymes to actually have symptoms, and that goes kind of hand in hand with CK. Thank you.
Yes, so I think there certainly is data and the inclination to do monitoring, but beyond just ALT. I think the most of the data is with ALT as being the most sensitive marker of hepatotoxicity, and it's used in the definition for drug-induced liver injury, but it's probably not the only marker that we can look at for determining whether dose reduction needs to be done or not with ETI.
Great. Well, I'm Jamie Duckers. I'm an adult CF physician based in the UK, and thanks to the organising committee for asking me to speak. So these are my disclosures, and I'm talking about ETI closing or widening the gender gap in CF. So there's really going to be 3 parts to my talk. What actually is the gender gap in CF? What do we think might cause the gender gap? And then lastly, what do we think ETI is going to do to that gap? So we're all very familiar with this, aren't we? The landscape of CF care has changed massively, hasn't it? So when CF was first described, children would die quite quickly with failure to thrive. We're now seeing the people with CF that we look after, they're going to school, they're getting education, having relationships, careers, families, they're retiring and having grandchildren. And of course, ETI and the modulators are playing a role in that. So here's some data from the CF registry in the US, and you can see that the median predicted survival there is 61. So if we take our twins who don't have CF in the middle of this picture, what is their life expectancy? So according to the Office of National Statistics, for the boy, the life expectancy is 88, and for the girl is 91. So you can see that we've got quite a way to go, but you can see, interestingly, there is a survival gap. And this survival gap, showing that women have a survival advantage compared to men, is a really consistent pattern. And actually, Alsted has said that there's no more robust pattern in human biology. So when you look at the human mortality database figures, women live longer from birth, and even at age 50, predicted survival is better than for men. However, we all know that CF bucks this trend. So women, female sex is independently associated with the risk of death. Females have been well shown to have decreased life expectancy with CF. And figures suggest around about 3 years shorter life expectancy. And the top right data there is from the Canadian registry, and you can see that the males are in blue and females in red. And then the bottom is from the UK CF registry. You can see in yellow, that's the total CF population. But in green, that's the men with CF, and in blue, that's women with CF. So it's not all about quantity. What about quality of life? So we know that outside the sphere of CF, women across countries of the world suffer worse health throughout life. Actually, CF doesn't buck this trend. Women with CF have more severe disease, they have worse lung function, they have higher rates of exacerbation, they have more Pseudomonas colonization, they're more likely to convert to mucoid forms of Pseudomonas, they tend to have transplants earlier, and they tend to have lower quality of life in most domains. So we can say that there is a gap. Women with CF have worse life expectancy, worse health. So in a sliding doors moment there, we've had ETI. The change is now ETI. So what's going to happen to that gap? So I guess it depends. Why is there a gap? What is the difference? Is it just that men are from Mars, women are from Venus, or is it something a bit more complicated than that? I went back to when they first found the spirometer, and this is what the first differences in sex showed. Vital capacity is decidedly less in women than men. Women don't seem to need air quite as much as men, and the theory behind that was there's something to do with the artificial constriction of the dress. So we have moved on from there, and so Raksha Jain's group have written quite a lovely paper, actually, with why is there a gap? What are the multiple things that are feeding into this potential gap? So I quickly take some of these. So women with CF do have smaller conducting airways at birth, all the way into adulthood, and this may impair mucociliary clearance. There may be a resultant increased susceptibility to infection. We know that women acquire Pseudomonas earlier, and we know that Pseudomonas confers a worse prognosis. We know that women with CF actually acquire other pathogens earlier than men. We know that women have more exacerbations than men. They're less likely to recover to their baseline after an exacerbation, and they're more likely to need treatment within the next 30 days of an infection. We do see a change in the number of exacerbations that women with CF have after they go through puberty. So it does suggest that there is a role for the female sex hormones. And we know that estrogen does contribute to a dysregulated inflammatory response. We know that women perform differently when they have CF-related diabetes with worse outcomes. And we know that women have lung transplants earlier than men. But interestingly, there's no difference after they've had that transplant in survival, regardless of the sex of the donor. So it does bring into question whether there is a role for CFTR dysfunction. So if we do think that CFTR dysfunction is significant, will ETI close that gap? So the pivotal studies looking at the phase 3 studies of ETI doesn't show any difference between men and women in their response. Admittedly, they weren't designed to look for that difference, but they did not find a difference. We know that the FDA website shows that ETI works similarly in men and women. And as far as I'm aware, there's no significant difference in PK for either ETI or I between men and women. We do have some data from the GOAL study looking at ivacaftor response, and that there was in this a greater decrease in sweat chloride in women than in men. But the Czech sweat chloride study that looked at over 1,800 people moving on to a modulator didn't find that same difference, so no particular difference between men and women in that. So then, if we do think that lung function is key to closing that gap with the ETI, what do we know so far? So kindly Jennifer's lent me this slide and was presented in the European CF meeting. We can see that in men, in boys with ivacaftor, they do have greater lung function, and they seem to have a slight increase in lung function compared to women. What about data from using ETI and lung function? So this is from Raksha Jain's group in Southwestern, and they took 250 people with cystic fibrosis and looked at their data for 5 years before ETI and looked at 2 years post-ETI. And the graph on the left there is showing that whole population of 250. The graph on the right is showing around about 100 people who were modulator naive, so going from no modulator on to ETI. And you can see there, the graph on the left shows no real difference between men and women. On the right, this didn't reach statistical significance, but there's a trend perhaps towards men having a greater response who have been naive to a modulator. So what about longer term? That was over 2 years. This is registry data from the CF registry, looking at longer term data on ivacaftor, so following people over 5 years. And there isn't actually a difference in men and women in the lung function over that 5-year period. We mentioned before pulmonary exacerbations are a key predictor of survival and quality of life. So what happens? We can learn from ivacaftor, again from the GOAL study, you can see that women have a slightly higher exacerbation rate on the left, and that they did have a significant drop in exacerbations, whereas the males did not. However, in Raksha Jain's population of 250 going on to ETI, you can see that actually, again, women had more exacerbations, but there was a significant difference in a drop, with men having more of a drop in exacerbations than women. And again, for data for longer period of time, this one is in ivacaftor, again using registry data. It's clear that women have more exacerbations. There was a statistical significant difference, but again, perhaps a trend that males had a response with fewer exacerbations. We know that Pseudomonas confers a worse prognosis. So what happened for people starting ETI who are on with Pseudomonas? We can see that the levels of Pseudomonas dropped, but there was no statistical significant difference in the response between men and women in this. And again, using that long-term evidence for ivacaftor, again, no difference between men and women in the amount dropped of the Pseudomonas. So again, we know that BMI is a predictor of how well people will do. So what happened to people after they started ETI? You can see that people's BMI increased. There wasn't a statistical difference between men and women starting ETI therapy with their BMI. So some data from our group, there is some, I suppose BMI is not the only answer, is it? We can look at body composition. So from our group, we found that, yes, BMI improved on ETI, but when you look at fat-free mass, and we know that in some other respiratory conditions, fat-free mass or skeletal muscle mass is a better predictor of outcome. We found that that increased in men, but not in women. And this is just one cut of a CT, which shows that post-ETI is on the bottom. You can see the lungs might not have changed, but this guy's done quite a lot of time in the gym. So muscle mass does change. We also found that there was an increased amount of women having normal weight obesity. So although your BMI looks normal, your levels of fat mass have increased. So I mentioned before it's important to look at quality of life as well. So this is data as yet unpublished from our group. So we took all of our 270 adults with CF who have gone on to ETI therapy and looked at their pre and post quality of life. And you can see that all the domains there in green of the CFQR is where there's a statistical improvement. So you can see there may be a differential response with women not really seeing an improvement in our group in the eating domain. Again, another reason it's important, if you're going to see a benefit with ETI, it actually needs to be taken. So what about adherence and tolerance? And that's something we see in the clinic all the time. So the SPC for ETI reports that the overall occurrence of side effects is similar, with the exception of headache and rash. So they are slightly more common in women. And then we looked at our local data, a little bit like the lady that first gave the video. How many of our people with cystic fibrosis actually continue with ETI? So I mentioned our 273 people we've currently got on. We only had a 1% dropout rate, just 1 man and 2 women. And actually people reducing the dose, just like that Amber in her video, we actually have 3%, and pretty similar between men and women actually reducing their dose of ETI. As far as I'm aware to date, there's no evidence about adherence with ETI. We have done a bit of work, this is under review for publication, from our psychology team looking at ETI. So we've used something called a Beliefs About the Medication questionnaire, a BMQ. And this simple questionnaire looks about how necessary people deem their medicine to be and what their concerns about taking that medicine are. So what we can see here is actually there was a differential response between women and men when we asked them after they'd started their ETI therapy. Both sets of people thought that taking ETI was necessary, but women expressed higher levels of concern about taking it. And you can see here there was a statistical difference. So women are more likely to worry about long-term side effects than actually taking ETI therapy. So we know from that balance between necessity and concerns that weighing that up, it can be very closely related to how people adhere to a medication. So in the diagram on the right, you can see that perhaps more men are likely to have higher necessity and lower concerns, so they're more likely to be accepting of taking ETI therapy, whereas the women also had higher feelings of necessity, but did express more concerns about taking it, so may theoretically be more ambivalent in the long term, and that might be associated with adherence. So other things that might be key to the gender gap, we're going to hear a talk about inflammation and whether it's still present after ETI, and is that different in men and women? There isn't a lot of data about the difference between men and women in glycemic control post-ETI therapy. There's lots of emerging interest in what's going to happen to the levels of sex hormones post-ETI and what's going to happen to the increasing numbers of women going through the menopause. Tracy Kazmersky's group did use the UK CF registry to look at parenthood. So we know that there are lots more people with CF becoming mothers and fathers, but what happens when you become a mother or father and you have CF? We know that your FEV1 decreases, you're more likely to lose weight, and you're more likely to have exacerbations. And women tend to have more weight loss than men. And we know that post-ETI, you can protect against the lung function loss, but it does appear that you may not protect against that BMI or exacerbation. There is going to be further information coming from the HOPE study and from obviously Mayflowers. So putting all of that together, if we were trying to predict the future, what we know so far is there seems to be a greater decline in pulmonary exacerbations on ETI for men. Women still have more exacerbations, and we know that pulmonary exacerbations are a key predictor of survival and of quality of life. We know that for some other respiratory conditions, such as bronchiectasis and asthma, may have worse outcomes for women. We know from our data that women may see less improvement in fat-free mass index. We know that they may have a differential opinion of ETI therapy with higher concerns, and they may experience higher side effects. And we know that there may be a feeling that not everybody sees the same quality of life improvement on ETI in every domain. So that all made me think that the gap's likely to widen. However, the UK CF registry is just publishing its 2023 report, and I'll take you back to the top one, which shows the yellow, the whole CF population for median predicted survival, and it's gone up to 64. And you can see that that green line is the men and the blue line is the women, and what you can see is that those seem to be converging, and the bottom graph is just looking at that number of years difference in median predicted life expectancy is falling. So it's against what I would have predicted. So what does the future hold? So the Lopez paper does suggest that people who are delta F508 homozygous and are maintained on ETA may have a survival well into the 70s. What we don't know going forward is how that looks for men and women with cystic fibrosis. We don't know the risks of cancer. They are at increased risk of digestive cancers, but what about gynecological cancer risk? We know as well if you live into your 70s and 80s, some of the key health problems are going to be ischemic heart disease and Alzheimer's, and we know that women and men outside the sphere of CF have different risk factors for these. So how will that work in cystic fibrosis community? Also, there may be further interest in what some other future therapies may look at treatment with oral contraceptive pill may have more women having HRT, and we know that these may affect the immune system and may have an impact. So in summary, I think I'm pretty firmly sat on the fence, actually. I don't actually know what's going to happen. We know that women have more exacerbations. We think that's clear. We know that exacerbations are bad. We know that potentially men have had a better improvement in the number of exacerbations. I think there's still ongoing inflammation despite ETI, and I know we're going to hear more about that. And we don't know what ETI is going to do to sex hormones, and we know that they're critical in the immune response. There's a suggestion that women may have differential beliefs. There's a suggestion they may have a difference of body composition on ETI, and they may have experience different adverse events or rates of adverse events. And it's true, we're seeing this survival, median predicted survival converging. Will it actually go the other way? And will women survive longer than men? We don't know, and we don't know how those future diseases are going to affect our CF population. So just some closing thoughts. I've completely oversimplified it because we know sex and gender is not that easy. It's not a binary thing, but for the sake of this talk, we've kept to that. And I know that we've kept discussing ETI, but are we going to see a group of people on ETI and the 10% not on ETI? And will those gender gaps be very different in those two populations? I think we need more data for that. And as Melinda Gates says, we can't close a gender gap without closing a data gap. And that's the real value of the registries. It's very fortunate that we're going to get some more answers come out from the sharing group. So the CF Foundation have funded further work in a women's health research working group. And I would reiterate, it's not always quantity. Quality of life is really important. And again, that's something we should really be focusing on, collecting data that is useful to the population with cystic fibrosis. And of course, to take it back to personalized medicine, how can we really deliver true personalized care if we don't actually know if men and women are different? Thank you very much.
We have time for one question. All right. Oh, there's one online. Let's see. So for all speakers, do you think routine ETI therapeutic drug monitoring is warranted in certain well, we're going to hold that for the end. But any other questions specifically for Dr. Duckers? Okay. All right, I'd like to invite Dr. Scott Segels to the stage. He's going to talk to us about inflammation after ETI.
Thank you. This standing room only crowd is a bit intimidating to me. For the people in back, there's some seats up front if you need any. Okay, you already did that joke? Okay. All right, so thank you for the opportunity to discuss whether inflammation is still a problem in people on ETI therapy. My only relevant disclosure is I've received grant funding from the CF Foundation for some of the data I'll be presenting during this talk. Neutrophilic inflammation is a hallmark feature of CF lung disease and central to the pathophysiology of bronchiectasis. Elevated levels of neutrophil elastase and other markers of inflammation are associated with lower lung function, bronchiectasis, disease progression, increased risk of exacerbations, and response to exacerbation treatment in people with CF. The new way to describe how airway inflammation interacts with the other components of both CF and non-CF bronchiectasis, including airway infection, impaired mucociliary clearance, airway remodeling, is as a vortex where each pathophysiologic step interacts directly and indirectly with each of the other components. Had we asked the question about is inflammation still a problem in people on ivacaftor therapy, we probably would have more confidently answered yes to that question. Studies of ivacaftor, the very first CFTR potentiator approved for people with CF and at least one copy of the G551D allele, yielded mixed results in terms of its impact on airway inflammation. This study by Katie Heisert and Pradeep Singh found that ivacaftor markedly reduced markers of sputum inflammation in a cohort of 12 adults with CF, most of whom were chronically infected with Pseudomonas aeruginosa. In contrast, in the G551D observational trial, or the GOAL study, several markers of inflammation in sputum, including in here, IL-8 and neutrophil elastase, did not change significantly through 6 months of ivacaftor therapy in a group with milder lung disease assessed by sputum induction and a group with more impaired lung function who spontaneously expectorated mucus before and 6 months on therapy. Studies of ETI therapy, however, are more consistently demonstrating anti-inflammatory effects. Let's begin with data from the PROMISE study. PROMISE is a multi-center prospective observational study of ETI in people with CF and at least one F508 del allele. The PROMISE study has been extended down to 6 years of age, but the data I'll be showing are in adolescents and adults greater than 12 years of age through 24 to 30 months of therapy. Participants needed to have a baseline or pre-ETI blood and or sputum sample collected and at least one sample at a post-ETI follow-up visit to be included in these analyses. Measurements of inflammation included in sputum, primarily obtained through induction if allowed at study sites, because again, this was conducted during the COVID pandemic, included free neutrophil elastase activity, calprotectin, a cytokine panel, and in bloodstream we measured high-sensitivity C-reactive protein, calprotectin, and HMGB1. The baseline demographics and clinical characteristics of the 223 PROMISE inflammation sub-study participants are summarized in this table. The average age of this cohort was 24 and a half years of age, and they were relatively equally distributed across these 3 age strata. About 50% were homozygous for the F508 del allele, and most of those had been previously on CFTR modulator therapy. The mean FEV1 of the cohort was 80% predicted. About 3/4 were infected with Staph aureus, and a little less than half were infected with Pseudomonas aeruginosa. And the microbiology data was based on their baseline sputum sample obtained before starting on ETI therapy. Now, the sputum cohort is a cohort of 148 individuals who again had a pre-ETI sputum sample and at least one post-ETI sputum sample. Their demographics and clinical characteristics were very similar to the overall cohort. Their lung function was just a little bit lower. All right, so starting with the sputum data, the proportion of participants with pre-ETI sputum samples who completed study visits and provided a sputum sample for assessment of inflammation was 90% at the 1-month visit. It was 40% at the 3-month visit, but this was the visit that was actually most hampered by the COVID pandemic and really made big restrictions at study sites where they could not perform sputum collection. And it was about 50% at the 6, 12 to 18, and 24 to 30 month time points. ETI was associated with significant and sustained reductions in free neutrophil elastase activity, calprotectin, IL-1 beta, and IL-8. It was also associated with significant increases in sputum IL-6 through 24 to 30 months of therapy. Serum samples were available from approximately 90% of participants with pre-ETI blood samples at the 1, 6, and 12 to 18 month time points. And ETI was associated with significant reductions in serum hsCRP, decreases in calprotectin at the 1 and 6 month time points, and decreases in circulating HMGB1 at the 12 to 18 month time point. Now we'll look at data from 2 European studies that reported on changes in inflammation through 1 year of ETI therapy. This first one being from Germany. This study enrolled 62 participants. They were a bit older than the PROMISE cohort, average age of about 30 years, more impaired lung function. The average FEV1 in this cohort was just under 50% predicted. Fewer numbers provided sputum samples at the post-ETI visits, but among those who did expectorate, they observed decreases in free neutrophil elastase activity and IL-1 beta at each of these time points compared to the baseline. Similar to what we observed in the PROMISE cohort, they did see increases in sputum IL-6, though it did not achieve statistical significance. In a single-center study performed in Ireland, 30 adults with CF were enrolled at an average age of 28 years, an average FEV1 of about 57% predicted. Spontaneously expectorated sputum was collected. Many of these adult participants could not expectorate sputum on ETI therapy, such that 14 of the original participants expectorated a mucus sample for analysis at the 3-month time point, and 10 of the 30, or a third, expectorated mucus for analysis at the 12-month time point. Among those who did expectorate sputum, they observed, like the PROMISE and the Germany study, significant decreases in free neutrophil elastase activity at both time points post-ETI. And among those who had blood samples available at baseline, it was about 18 of the initial participants, they observed decreases in circulating CRP at these post-ETI time points as well. So even though inflammation decreases on ETI therapy, it remains present. Returning to the PROMISE data, if we look again at sputum measurements of free neutrophil elastase activity, the lower limits of detection of the assay is 0.5 micrograms per ml. Most people without lung disease do not have detectable elastase in their airways, meaning the detection of free elastase in people with CF post-ETI indicates the probability of ongoing proteolytic activity, albeit to a lesser extent, a much lesser extent than was observed pre-ETI. Looking at CRP, when I superimpose our lab's reference values for what constitutes a normal CRP, you can see that on average, participants had CRP levels pretty close to normal pre-ETI and then declined below the lower limits of the normal range post-ETI. So much less in the way of overt systemic inflammation on ETI therapy. Going back to the data from Germany, they enrolled 10 healthy control participants in which they collected mucus by induction. You can see that the healthy controls had little to none in the way of detectable airway inflammation, very little to none free neutrophil elastase activity, IL-1 beta, and IL-8. And while levels declined significantly among the people with CF treated with ETI, they didn't quite return to what appeared to be healthy levels, indicating persistent airway inflammation. So another reason to suspect that inflammation is going to remain a problem in CF is that bacterial pathogens persist in CF airways post-ETI, and failure to eradicate pathogens will likely lead to a persistent inflammatory response. These are data from the PROMISE microbiology study demonstrating that ETI use is associated with decreased density of traditional CF bacterial pathogens in sputum, but airway infections generally persist. This study was led by Pradeep Singh and Dave Nichols. The graphic on your left is demonstrating that the proportion of subjects who provided sputum samples who were culture positive for these CF pathogens. There was not much of a change in Staph aureus detection across the 6 months on ETI therapy. In contrast, in those with Pseudomonas aeruginosa and Stenotrophomonas multifida, they did observe a decline in prevalence rates 1 month into therapy that seemed to stabilize thereafter. The graphic on your right here is showing the sputum culture density of Staph aureus and Pseudomonas aeruginosa in those participants who cultured these pathogens pre-ETI therapy. And you can see an approximate 2 log reduction in Staph aureus counts and Pseudomonas counts that are achieved at the 1 month time point and continue at the 3 and 6 month time points, indicating that you have this marked initial decline that seems to be followed by a relatively new steady state, at least through 6 months of therapy. This study reports on the effects of ETI therapy on the sinus or upper airway microbiota. Sinus swabs were obtained from the middle meatus of 38 adults with CF and chronic rhinosinusitis. In samples where Pseudomonas species were detected, the pre-ETI median relative abundance was about 29%, while the post-ETI median relative abundance was less than 1%. Despite the reduction in Pseudomonas species relative abundance post-ETI, it remained detectable at low levels in all 14 subjects. And looking at other bacteria post-ETI, they observed increased or high sustained relative abundance of staph species in the sinus samples. So if you believe in the unified airway hypothesis, that the entire respiratory tract, the upper airways, the lower airways represents a functional unit, then these data indicate the pathogens, including Staph aureus, will continue to be important in the setting of ETI therapy. Why then is the persistence of bacteria in the airways problematic? Because there are many historic studies linking airway infections with airway inflammation in CF. I had to go back a couple decades to the archives for these data. These are data from an investigation surveying for Pseudomonas aeruginosa in the lower airways of infants and young children with CF through the use of bronchoscopy and bronchoalveolar lavage. Several markers of inflammation, including neutrophils, IL-8, free neutrophil elastase activity, increased with the number of different bacterial pathogens detected, such that those with 3 CF pathogens detected had the highest associated amount of lower airway inflammation. This is just one example demonstrating that the mere presence of bacteria stimulates an airway inflammatory response. Additional evidence that inflammation is a problem is if anti-inflammatory therapy is beneficial in those on ETI therapy. Here's an example. These are recently published data of a phase 2 clinical trial of a compound called LAU-7B, a novel oral form of fenretinide that's purported to act on cell membrane lipids to control inflammation. This trial enrolled CF participants who are on CFTR modulator therapy, including ETI. LAU-7B showed reduced loss of function relative to placebo, including those who are taking ETI therapy, though differences between the arms did not reach statistical significance. They also measured biomarkers of inflammation as secondary endpoints, and focusing on circulating calprotectin and CRP, both exhibited differences between arms in favor of the LAU-7B group, again, not reaching or achieving statistical significance. Further subgroup analyses looked at changes in these circulating biomarkers based on whether they were on ETI therapy. Now, these data do not clearly demonstrate a robust anti-inflammatory effect, but they raise the possibility that reducing inflammation could attenuate a loss of lung function even in those on ETI therapy. So I'll begin to wrap up by asking why else we should care about inflammation in CF. As if adults with CF are not facing enough in the way of problems and challenges, I worry that a lifetime of chronic inflammation could be another problem with important health consequences for adults with CF. Inflammation is linked with heart disease, strokes, dementia, aging. This was a manuscript from the New England Journal of Medicine that came to my email and attention, while I was preparing this talk. It's a study of healthy U.S. women followed for 30 years. It reports that a single measurement of high-sensitivity C-reactive protein, LDL, cholesterol, and lipoprotein levels at baseline was predictive of experiencing a major adverse cardiovascular event, which was a composite of heart attacks, strokes, or death from a cardiovascular cause during the 30-year follow-up period. Those with higher CRP levels at baseline had a higher risk of a major cardiovascular event independently, and combining a higher CRP either with a higher cholesterol or a higher lipoprotein level was even more strongly predictive of experiencing a cardiovascular event. Inflammation takes a toll on our bodies as we age, and we're going to need to pay attention to this in adults with CF. Why else should we care about inflammation? It's because it's likely to be an important safety measure of in clinical trials of nucleotide or genetic-based therapies. Also, thinking back to the vicious vortex of bronchiectasis, where he said that chronic inflammation contributes directly and indirectly to impairments in mucociliary clearance and to bacterial clearance, as well as data that really shows a very strong association between measurements of inflammation and bronchiectasis. I would argue that modulating inflammation may be more effective at preventing against progression of structural lung injury, more so than mucolytics and antibiotics. I'm going to end with a series of questions I have, and you may have as well. I don't have answers to these questions. What is the durability of anti-inflammatory effects of ETI over the long term? And how will persistent airway infections affect inflammation? What amount of inflammation is clinically meaningful and associated with clinical disease, either lung function decline or cardiovascular events in adults? How should we be monitoring inflammation, especially airway inflammation, in those who are no longer able to expectorate mucus on ETI therapy? Options include bronchoscopy, sputum induction, breath analysis, circulating measurements, possibly imaging. And would those with residual inflammation benefit from existing symptomatic therapies, inhaled mucolytics, inhaled antibiotics, azithromycin, and/or targeted anti-inflammatory therapy? With that, I'd like to thank Jennifer and Jerry for the invitation to speak at this symposium. My colleague and collaborator, Brandy Wagner, who's a biostatistician. I hope Brandy's somewhere here in the audience. I just can't see with all the faces here. I'd like to thank the CF Foundation's Therapeutics Development Network that's overseeing the PROMISE study, the TDN sites and investigators, and the PROMISE inflammation sub-study participants who come to clinic to provide mucus samples and blood samples. The measurements of inflammation are performed in our pediatric CTRC core lab at Children's Hospital Colorado and the University of Colorado Anschutz Medical Campus. This lab serves as the Center for Biochemical Markers for the CF Foundation. These are my institutional affiliations and my funding sources. Thank you. Jennifer, I'd like to point out my talk was exactly 20 minutes.
I see that.
Yeah. And it's still just 20 minutes.
So we'll start with a few questions for Dr. Sagel and then move on to any general questions for all of the panelists.
Hi, really great talk. Really enjoyed it. I wonder if you could comment, thinking about this intersection of inflammation and ETI. And I'm thinking about the recent paper by Mike Welch's group that just came out this summer, where it talked about the role of inflammation is sort of being required for most effective CFTR transport with ETI in these cultured cells.
Yeah, it's really an interesting line of evidence, and I'm not totally savvy with it, but it's as if that you need some degree of inflammation to maintain activity of CFTR or to enrich activity of CFTR in the airways. I will just, point out some other data, in this regard, which is that, when we look at changes in inflammation and relationships to, the different clinical outcomes, and if we focus here on, FEV1, for instance, we see, in those who are dichotomized with a lower lung function versus a higher lung function, we see a greater reduction in neutrophil elastase activity among those with lower lung function. We also saw a trend, or in this case, a significant greater decrease in inflammation if we're looking at neutrophil elastase activity among those who are infected with Pseudomonas versus those who are not infected. We didn't see differences in any measurements of inflammation based on previous modulator use. So again, where there had been some change in CFTR activity in the airway, we didn't see changes in that regard. The other thing I'm not showing here in this slide is these I was looking, but I didn't include in this slide deck, is that reductions in inflammation did correlate with improvements both in lung function and in improvements in respiratory symptoms. So those with a greater reduction, it was an inverse correlation, but those with a greater reduction in free neutrophil elastase activity had a higher improvement in FEV1, a greater improvement in respiratory symptoms. So it seems different than what like Mike Welsh's group and the North Carolina group has in a sense argued. So I don't have a great answer other than to say, yeah.
And that's also in vitro data, too, they're looking at. So.
Okay. Thank you. Thanks for the comment.
Any other questions for Dr. Sagal?
Yeah, I had a question. So I know this data is really new, but there's some pretty big error bars, on a lot of those markers. Is there a cohort that is persistently non-responsive with regard to inflammation, and do you think, or is that just noise up and down, visit to visit, or?
There is, it's a good point. There's just inherent variability in the sputum measurements of inflammation. We have not dichotomized in any way that, those who don't seem to have any change. The reality is most people had a reduction in their measurements of inflammation. So I'd have to arbitrarily define what a cutoff is that's not a big change in neutrophil elastase versus a group that really is a big cutoff. The numbers are not great in that regard, again, because there's not many who didn't experience a decline. So I can't answer that question at the moment, but we will certainly look at it that way. So thank you.
Well, if you find that cohort, if you can find out if they're women or men, and then also check their tezacaftor levels.
All right.
That would really tie this
whole
together.
That's great.
I think we do have a few. Do you want to go ahead and?
Yes. So we have 3 questions online. None are specific to Dr. Sagal's talk, but more general. One is, did you find any difference between pancreatic sufficient against pancreatic insufficient patients in relationship to drug concentration variability? And so, Dr. Behringer, you may also have some comment on this, but at least in our real-world studies, the vast majority of patients who participate are pancreatic insufficient, and so the sample size for pancreatic sufficient patients is pretty small, but some of that data may be coming out in the PROMISE data soon.
Yeah, I think the only other thing to add is what was commented earlier, that the biggest difference for absorption has to do with whether you use fat or not. So that's probably a better predictor if you have a high-fat meal with the tezacaftor than whether pancreatic insufficient or not. They're basically all pancreatic insufficient in on enzyme.
There's another question on plasma concentrations relating to cellular levels. And so I talked a little bit about that, and I know that Dr. Behringer also commented on some simulations using cellular in vitro data for ECs. The question is, how do plasma concentrations relate to cellular levels, both cells that you want to target and those that you do not, and can this explain variability? I will say that, you know, we have done some studies in ivacaftor. There's also some in vitro data looking at various modulator therapies. Ivacaftor is somewhat unique in terms of its accumulation inside cells. A number of different studies have shown that it seems to be higher intracellularly compared to plasma, but that is not true for tezacaftor or ivacaftor. To my knowledge, I've seen a few different studies that look like it doesn't do that. And so in terms of the cells we want to target and those we do not, I don't think we have a lot of control over that, but at least as far as epithelia goes, I'm not aware of a whole lot of data of differential uptake into them, but certainly other drugs do have potential for differential uptake into different tissue types.
And the reason I asked is because if you're accumulating the drug in cells that, let's say, you don't want to target, smooth muscle in the intestine, neurons, etc., that could help explain adverse events theoretically. And so I'm just wondering how the PK data that you all presented, which is very lovely, relates to the concentrations that actually get into cells where you may be causing adverse events.
Yeah, so as far as adverse events go, I think that is a question that's really ripe for study. I know there's a number of people who are looking at, like in the liver, for example, for drug-induced liver injury, and that there are great models for that. Dr. Elena Schneider-Fuchsik, I'm not sure if I'm saying that correctly. Now, if you're in the audience, I'm a fan. I'd like to meet you. I never have. But she has studied specifically looking at lots of different tissues, particularly in the nervous system in animal models. And that's really fascinating as well. So there is differences in the uptake into those cell types across gestation and at different ages. And so I think those are questions that we really need to be thinking about and answering as it relates to side effects.
Another aspect of that is, as I mentioned in my talk, these elexacaftor and tezacaftor are substrates for PGP, which is on the blood-brain barrier. And so there could be, polymorphisms of MDR1 that cause differences in uptake or crossing into the blood-brain barrier, or inhibitors of PGP that may be changing the distribution of drug in the brain that could account for adverse effects. But that certainly needs to be investigated.
And there is one more question for all speakers. Do you think routine ETI therapeutic drug monitoring is warranted in certain populations to guide dosing adjustment?
Yes.
We just need more data to interpret it.
Yeah, I mean, my take is that, for most of our people, it's very reassuring that, that most of their levels are in the mid-range and they're not outliers. When we do see an outlier, when we've repeated some very, very low levels, they've come back normal. So I think, there's a lot of value to, that reassurance. I would say that, kind of circling back to the gender issue, we do have a highly significant proportion of women that have modified their dose compared to men, and I think you do too in some of your data. So we're keeping an eye on that. I think there was a report, I think, of increased rash with women as well. So I think the jury's still out a little bit on that issue. But the real question is, for people that modified their dose, what was it before they modified the dose? Especially, individuals that have pretty high levels on a modified dose. Some of those might have been very, very high. So I think, we're looking to go from just a random point to a more modeled curve, and we'll have a lot more information then. But I think, the jury's still out, I guess. We haven't changed anyone's dose based on therapeutic monitoring yet, but I think at some point, we probably will.
So recognizing that there are a moderate number of people who are lowering their dose, and recognizing that ivacaftor clearance is more rapid and has to be dosed twice a day, if you wanted to do a proportional reduction in dose, what would be your recommendation to do that? I see people dropping off the second dose of ivacaftor and leaving the morning dose the same with all three. Does this make sense from a pharmacokinetic approach?
I mean, I would say from a real-world data, ivacaftor is the one compound that is pretty consistently the highest across multiple studies and multiple people. And so I think, ivacaftor is one that I have noticed would be the easiest target to reduce. But you still don't know exactly who that is unless you're checking before you reduce the dose and after, and a single data point with as much variability as the main thing I hope that people take away from the data is that it is in real world use, it's highly variable. There are lots and lots of factors that contribute to a single day. And in day-to-day variation, we really don't have that information right now. And so, having it before you change the dose and then having it after you change the dose based on two single data points is probably not as good as if we have a better understanding of where that person lives most of the time, as we had multiple data points. So I think there's just a little bit more data to understand exactly how to interpret it. But yes, I think that ivacaftor is a commonly dropped dose, and that data would support that.
But where people live most of the time might be widely fluctuating too. It's not mutually exclusive. I think a lot of our patients do have widely fluctuating data day to day.
Any other questions?
Mike Narkowitz, Colorado. It's really a question on liver toxicity. So I've been struck by the fact that we actually don't know the mechanism of liver injury, having personally reviewed almost every case out there. But you have some data that I would be interested in trying to understand. You have a lot of subjects who have levels above EC90 in your data. And you've also got the data you presented, Paul, on sort of reduction in dose. But it's a small minority of individuals who really have liver toxicity. So when you look across the data you have currently, where do you place the liver toxicity patients, and is there any consistent pattern with their levels, acknowledging Jerry's comment that it's variable? Because if it really is dose dependent, you should expect most of the individuals at the high level to have liver tox, and the data I've seen doesn't really seem to support that. So if that's the case, do you have other ideas about mechanism and why reduction might help? It's a long question with not many answers.
Yeah, I think we need much more information about measures of drug exposure in patients before and then after you see the LFT rises. So how you got there might be different than how you recover. So that was kind of our argument with doing dose reduction once we saw the increased LFTs. And we did note that there were improvements in liver function tests. It's not controlled. What would have happened had we done nothing? Not sure. But I think especially during the pandemic, when we had difficulties in getting patients in to do this frequent monitoring, we were a little more conservative and just made adjustments. And fortunately, I think it worked out in terms of their lung function being stable and LFTs recovering.
Yeah, I think, one other concern is that, we've basically uncovered, a number of people that were heavy alcohol users on tezacaftor, and that we weren't aware of it until we saw them back after starting tezacaftor.
All right. Well, I would thank you all for staying to the very end, and thanks to all the speakers. Thank you for coming and giving such great talks. We appreciate it so much.